welcome everyone. Let me show you my PhD research, Changes of the Mental Health Through Pediatric Cancer Experience. My name is Márton Szabados. I'm a pediatric resident at the Pediatric Center Semmelweis University. My supervisor is Miklós Garami. Mark Hernát, Fői Gergely Agócs, and Szilvia Kisdala are helping me to reach my vision, which is that in the future, and hopefully in the near future, childhood cancer patients and survivors will live a rich and full life. And I'd like to take a part of it by establishing a well-designed follow-up system and focusing on the quality of life and the psychological well-being of these patients. Here you can see the first two steps to reach that mission. The first one is a meta-analysis with the title Association of Tumor Location with Anxiety and Depression in Childhood Brain Cancer Survivors. Yeah, so pediatric brain cancer survivors have still an unacceptably high chance to develop affective disorders. For example, major depression shows itself in 20% of these patients with all its consequences. We also know that different areas of the brain are responsible for different functions. So there is a phrase, growing in the deficit, which basically means as the child gets older, all the disease grow into them also and may show these consequences, and affective disorders may show themselves lately. So therefore is a long-term follow-up from these children from a young age highly recommended. And with the right time diagnosis and the right time treatment, we can decrease the recurrence and also the severity of these diseases. So my aim was to identify that among these different brain tumor locations, which of these affective disorders have the highest prevalence. And that led me to the clinical question: does the location of the tumor predict the occurrence and the types of affective disorders in children with CNS tumors? And I hypothesized that there is an association between them. So the search was conducted at the end of November in 2022, and after the selection process, I had 42 eligible articles, which are cross-sectional and retrospective cohort studies. So to the results, in here you can see two forest plots showing the prevalences of depression and anxiety. The analyzed subgroups were based on the anatomical separation of the brain. So you can see infratentorial and supratentorial brain tumor survivors. The measure of effect was the prevalence of depression and major depression and prevalence of generalized anxiety disorder. The diagnoses were made by professional psychiatrists. You can see that there is a huge level of heterogeneity in both studies, which are mainly caused by the different follow-up times the different studies used, and also the subjective part of the diagnosis itself. So to the exact results, we didn't find any statistical significant difference between the two subgroups. But I'd like to highlight the total prevalence in both cases is 22%, which means that 1 in 5 these cancer survivors will suffer from major depression or anxiety. We also analyzed different scores, depression and anxiety questionnaires, where the subgroups were the same, and the measure of effect was the standardized mean scores of the different questionnaires. As a result, we found that infratentorial brain tumor survivors score significantly higher scores in both depression and anxiety questionnaires, which means so higher scores mean worse outcomes. As a limitation, I'd like to, and I have to, highlight the lack of data about the follow-up times. So we could have no clear conclusion about the impact of the follow-up duration, but actually we can look at it as a strength. So with our study, and our study pointed out many missing informations that will be needed for a more precise follow-up for these survivors. As a conclusion, I can say that brain cancer survivors have significantly more emotional impairments compared to healthy population, and infratentorial brain tumor survivors have a higher risk to develop anxiety and depression. and also that standardized measurement tools and defined follow-up times are crucial for the accurate analysis of this topic. We will use this knowledge and put a more closer psychological follow-up for these patients, focusing on the infratentorial brain tumor patients. And for future research, we highly recommend prospective cohort studies and universal and harmonized questionnaires and measurement tools. So our study was published in the Child and Adolescent Psychiatry and Mental Health at the end of October last year. To my second project, it's the Hungarian linguistic and cultural adaptation of the Minneapolis-Manchester Quality of Life instrument. In the last few years and right now, decades, in pediatric oncology, the focus shifted more towards the long-term effects and the quality of life from the survival itself. Heart-related quality of life is a multidimensional construct that affects the work, education, and social status for these people, also the autonomy for the individual. So cancer patients and cancer survivors have huge impairment in domains of their quality of life. And we don't really have a specific quality of life instruments focusing on childhood cancer survivals right now. So my aim is to provide a questionnaire in Hungary focusing on the quality of life for these patients, and with that to establish a better follow-up system. This questionnaire is a self-report instrument for the ages between 13 and 20 years. It has 46 items with 7 different factors, for example, body image, outlook on life, psychological functioning, etc. I'm ready with the translation process, and I've got the ethical permission to perform my study. And right now, I'm at the data collection process, which is a test-retest analysis. So we included 46 patients with central nervous tumors that are on active treatment, 46 patients off treatment, so who are ready with their active ongoing treatment, and 46 healthy controls. So after the adaptation, I'd like to use this questionnaire in the everyday work, so for example at the checkup visits, and implement this questionnaire as a standard and regularly used follow-up tool in the National Pediatric Cancer Registry of Hungary, and then to use this questionnaire as a measurement for a prospective cohort study in the future. I'd like to submit the second project at the end of May this year. And I'd like to finish my presentation with a quote from Noam Spencer: "Mental health is not a destination, but a process. It's about how you drive, not where you're going." Thank you for your attention.
Congratulations, Márton, on your presentation. And I have a question regarding to your second study. And I would like to know if you have already previous data and regarding which domains of quality of life are affected in those patients.
Yeah, thank you for your question. For my study, I haven't really analyzed the data yet, but from previous studies, I can confidently say that for these adolescents and young adults, the social part of the quality of life, especially the reintegration in school and searching for work, is the most affected. Yeah. But like all domains and all the parts is affected, but I can highlight that.
I would like to know whether you know if this questionnaire is widely used abroad or whether they use it as a daily manner.
Yeah, thank you for your question. This questionnaire is widely used in the United States and also in Asia. So my answer is yes. And it's kind of a new one. It was developed in 2015 in the USA, and yeah, so they are using it, and I actually chose it because it was developed by a really professional oncopsychologist, which, yeah.
In your first topic, you have the hypothesis that because of the location of the tumor, there must be some difference in the behavioral changes, anxiety, and so on. Okay, this is just due to the location, really, or not? What about the therapy? It can be also changing? What do you think?
Yes, of course. There are many confounding factors, and one is the therapy itself. There are some studies which ask if the therapy will cause any differentiation. So yeah, it will. It's a confounding factor in my study, but for brain tumors specifically, the used chemotherapy might be different, but the general approach for these brain tumors is the same. So surgical treatment, then radiotherapy, then chemotherapy if needed. So yeah, it's a bit different, but there is not a huge difference between the different tumors and the treatments.
Do you think that psychological variables can act as moderating variables in this case? For example, when thinking about the future, incorporating any of these could help you find protective factors or risk factors, like incorporating family history of mental disorder or the cognitive triad, etc., etc. So do you think these could help you in the future to find these variables that affect this connection that you found? Thank you.
So you mean the locations?
Yes, because there's a clear connection.
Yeah.
But do you think that these psychological variables could affect the strength of this connection either in a positive or a negative way? For example, a previous history of mental disorder in the family could increase it, or some other variable could decrease it?
Yes. So short answer will be yes, in my opinion. We're actually doing a follow-up study for previously treated medulloblastoma patients. That's an infratemporal tumor. And we are doing half-structured interviews with them where they can tell everything like that you asked, and all various factors. We don't have specifics yet, but I can see a lot of ways that we can use and then count as risk factors in the future. So yeah, I see the path.